Started your 2 minutes.
Ma'am, excuse me, who is going to present?
Asking.
Yeah. Okay.
One more slide is there.
Okay. Okay, next slide.
Started.
Hello, I'm Taskeen, the ST5 in the department, and you are?
I'm Prajakta. I'm the ST2, the new ST2 trainee in the department.
Okay, nice to meet you. Okay. How's everything going in the department?
Yeah, I'm really happy. Things are quite good.
Okay, let me tell you, whenever you have any difficulties or anything you want to sit out, you can just contact any one of us. We are here to support and help you always, okay?
Oh, yeah, thank you.
Okay, so I can see today that you're here today as we want to discuss about the twin delivery. Am I right?
Yeah.
Okay, that's nice. And is there any specific reason why you chose this topic?
Yeah, actually, I'm on labor ward duty currently as a ST2 trainee, and there is a patient with twin in labor.
Oh, nice. I'm so happy and I appreciate your efforts of, as you're keen to learn. Okay, we'll together go through this, the conduct of twin delivery. How is it done? What are the preparations? Okay. And in the end, I'll be giving you some resources also, and I'll be also taking the feedback from you. How does this sound to you?
Oh, yeah, that sounds very good.
Yeah. Okay. So once we are, encounter a twin delivery, like in this case, you have a multipara in labor. So once she comes here, we have to review her notes, okay, and see for any medical or some risk factors in the patient, okay. Thereafter, see whether the patient is term, what about her previous obstetric history, as usual. Thereafter, we have to focus on the babies, like whether the babies are term and what is their, presentation, especially of the first baby, as it will determine about us, whether we have to conduct the delivery. So you have to rule out any contraindications to vaginal delivery, like if the first baby is non-cephalic or if there's some other reason like placenta previa. Am I clear to you so far?
Yes, quite clear.
Yeah, and let me tell you, anytime you are want me to repeat, you can just stop me and ask me, okay?
Mhm.
While we have this patient in labor, then it should be, consultant-led care, and we should be prepared for the twin delivery in terms of like we should have the two skilled midwife attendants, the pediatricians should be informed, the theater staff should be informed, as well as there should be early IV access to the patient, as this patient can as a high risk of any postpartum hemorrhage. So early IV access needs to be established, and continuous electronic fetal monitoring with a dual set needs to be ascertained. Okay, so
Yeah.
yeah, if we see the first baby is twin, so let labor progress on its own. It will be like any other, cephalic delivery. So once we have delivered the first baby, okay, keeping in with all the necessary arrangements, then we hand over the baby to the pediatrician. So after that, you need to have an assessment, okay, of the patient in terms of what is the second baby, what is the lie of the second baby, what is the presentation of the second baby, and how is the fetal heart. So you can have 30-minute interval if everything is okay, like the baby's heart is okay. You can wait for 30 minutes and up to the delivery of the second baby. In the meantime, like if we don't get contractions, you may start the syntosnon, okay, for the patient, and also we'll connect the, as usual, the electronic fetal monitoring, the CTG. And let's suppose if the baby is, it's not fixed yet, it's not engaged, we'll wait till the presenting part gets engaged. Okay. So
Okay.
once it's engaged, so if it happens that like the second baby is breech, we can just go for an we have to call our senior and we can try the external cephalic version before the membranes are ruptured. Okay, so as to turn it cephalic, but it should be done by an experienced obstetrician. Am I clear to you so far?
Yeah.
And do you have any questions till now? Any inquiries?
No, I just wanted to know, do we need to give episiotomy for these twin deliveries?
Oh, it's not necessarily. It depends. Like in every patient, if we assess that there is something like there is some disproportion, or if the baby is not coming, like for any other indication, it's not specifically for the delivery. Okay.
Okay.
So once we see the second baby, if it happens to be a breech, we can go for external cephalic version. Okay, under the strict fetal heart monitoring. However, if what happens if it's a breech delivery, now it's going on spontaneously. Only what we have to do, a skilled attendant needs to be there to take care. Two cots should be available. One will be already in the baby, and second one for this baby. So third one, we can assist this as an assisted breech delivery can be done. However, in some cases, there what happens, there occurs fetal distress or the fetal heart is not okay. So it needs a trained obstetrician. So what can we do once the presenting part, like as I can show on this mannequin, like once this presenting part gets fixed, okay, we can rupture the membranes, because if early we rupture the membranes, there are high chances of cord prolapse. So once we rupture the membranes, we can do the internal podalic version. What does it mean? Like with our this dominant hand, we take a long gloves and just introduce it into the uterus and take hold of the baby's feet, then gently pull it through the cervix. Okay, but it has to be done by an experienced obstetrician who is well trained in this maneuver. So once we go for internal, first we rotate the baby, okay, internal podalic version. We just
Okay.
take the to the cervix and go for the breech extraction, okay. But prior to that, we have to ensure the analgesia to the patient, okay, and as well as a proper informed consent has to be taken from the patient, okay.
Yeah. Okay,
Yeah.
got it.
So if this maneuver is not done or it's not successful, we can go for the cesarean section also. So after that, the one of the important things in in twin delivery is that they're at high risk of postpartum hemorrhage. So what we have to do, we have to take care of that by implementing the active stage of the active management of the third stage of labor. And for these patients, once they enter into labor, we also have to ensure the group and save has been done. Am I clear to you so far?
Yeah.
Yeah. And do you have any questions, or you want me some step to be repeated?
Uh, Actually, I just wanted to know uh, one more thing is that
Okay.
do we need to have ultrasonography in the labor ward? Is it
Yeah,
necessary?
that's a very good question. I really appreciate this. Yeah. So once if we are not sure of the presenting part, either the first baby or the second baby, we need to have a in ultrasound in anticipation, so that we can be sure enough the what is the presenting part. So after the delivery of the first baby, again we can do a scan to locate the baby's presentation, and if it is breech, what type of breech it is, so as to minimize any complications which can happen if it's misdiagnosed. That's a very good question, and I can see that. And can you just enumerate the things which I have discussed, like when the fetus distress is there, what steps we'll be taking?
Uh, no, it's okay. That's it.
Yeah, yeah. So I'll be also giving you some resources, and then you can go through that. And you have got some guidelines also. You can go through them and strategy videos. And if you have a prop, and once we have another delivery in the delivery unit of the twin, I can also ask you to come and assist or watch that. Is it okay for you?
Yeah, I will be happy to come and assist you. Thank
Yeah.
you.
And
It was a
how
very
was
nice session by you.
okay? Thank you, and hope to see you. I'll be sending you the resource links also. Okay. Thank you.
Yeah. Okay. Your own reflection, then I will be giving my feedback. People who wanted to comment on her performance can also comment. Open to discussion. Okay. Asking your own reflection.
Um, yes, ma'am, it is a teaching station. So we need to have a rapid building, and we need to set an agenda for this discussion, and then we have to actively involve her and check her understanding. So regarding the mannequin use, we have to use all those. I forgot to mention about cord clamps. They should be, two or four in number, and also the educate trained staff, the midwives, and they should be present, and two cots should be available for conducting the twin delivery. And yes,
Good. Anybody wants to comment on her performance? Anybody?
Ma'am, that was a
Yes, ma'am.
wonderful.
Yeah.
No,
Yeah, Shash.
she's very excellent, mashallah. But some points in
Points
her,
she missed.
mhm,
Yeah. So
yeah,
can you enumerate
like
those points?
yeah, like hands-on technique. She must tell the trainee that you can grab the baby like this, you can do like this, and use all the provided mannequin.
Yeah.
This is
If the mannequin
mhm,
is there, allow trainee to do a hands-on technique.
yeah,
I will
yeah,
teach you. Okay. So at least EPV, IPV, ECV, those two. Otherwise, FT&D we do not need to teach. Okay. One good point. Okay.
Ma'am,
Anybody else who was there?
ma'am Shaista.
Yes, Shaista.
Yes, ma'am, that was a wonderful presentation. She was fluent and she had a good grip on the topic,
Topic. Yeah.
uh, which I noted one point. She told if patient is breach presentation, then um, then either we can manipulate, means external cephalic version and internal podotic version. So and breech extraction she also told. But specifically, we have to mention the name. If the baby, second baby is in transverse presentation, then we
Yeah,
can opt for internal podalic version followed by breech extraction. This is only the point which I case.
correcting.
Otherwise,
Okay.
nice presentation.
Very nice
She performed
presentation.
very
Yeah,
well.
very
She
nice.
showed
Okay.
good presentation.
And also maybe the risk of cesarean section during delivery.
That is okay because we are
It's,
conducting anyway. She has said that the theater needs to be involved. Okay,
yes,
so if
yes.
at
We
that
told about
point,
number. It is
yeah,
important
so
to
it's
ask about number.
okay. Yeah. Mm, anybody is having anything as again? Okay. Okay, only minute points what I wanted to tell you, Dr. Taskin. Very nice presentation, very crystal clear idea. Whenever you started, you know the module and you know how to approach in the teaching task. Okay, so you approached in that. But when you wanted to build a rapport with a trainee, I always say that in teaching task, do not ask them their name. Always address them by name. Okay. Here, I think the name was not there. Okay.
Yeah, I was not sure what is the name.
Yeah. Yeah. So, in this scenario, it was not there, but otherwise, if the name is there, ensure that you will be addressing them by name. Okay. So, that is one thing. In this scenario, the name was not there. Now, coming on to the next point. Mm, what is the objective? What is there in your script? What's you wanted to know? What are your objective? Ask this, something like setting agenda. So what we are going
Thank
to learn today, that one question will give us you a guidance. Okay, here at least they had been mentioned that what you have to say, that prerequisites, explain ST1 essential preparation or prerequisites. Then to conduct a twin delivery, that is hands-on technique, and demonstrate how you have been successful in task of teaching. So demonstration means you are going to perform it, and then the ST2 will be performing the task. So that is demonstration. Whether there is any other points which are there, so okay, then this point you missed out, but then you completed that. What you are going to, I wanted this you to ask to the trainee. You assume that we are going to do this. So you can ask here to the trainee, so that you will be very much sure that you are going on a right track. This is one point what I wanted to tell you. Have you seen conducted this you asked, and what do you know about twin delivery? What are your ideas about twin delivery? Did you ask this question?
No, I missed that. Yeah, about
Taking
ideas about
background,
what.
that is starting point. No, I have not seen. I have not assisted, and I I have read about it, but I have read about it. Okay, so that one point you had missed out. Okay. Presentation of first twin, did you mention? Contraindication you mentioned.
Yeah.
Did you
Mentioned,
ask?
ma'am.
Mentioned?
Yeah, ma'am.
Okay.
She told first twin to be cephalic. Yeah, she told.
Yes, that I missed out. Okay. Then checking knowledge of IPV, ECV also. When you were explaining, you explained what is IPV, what is ECV. So again, you have to ask here whether she or he is aware about IPV and ECV. Hmm? These are my minute points what I had mentioned here. Uh, the points which has been missed out are there, which we will go through the answer key. Whenever you say IPV, what is the risk during doing the IPV? You have to mention, it will be always better that you will be mentioning whenever the IPV will be doing the chances of cord prolapse. So these are small minute points which are there. We'll just go through the answer three, but apart from this, very nice task, very nicely done. Okay. My answer key includes introduction, rapport building, ruling out bullying, uh, aim of twitching, twin vaginal delivery for first cephalic baby. Appreciate why you asked here. Okay, very why you wanted to learn. You asked me any particular reason for this teaching session. Set objective. So what actually you wanted to learn today? This is one question. Will okay, you were on a right track. You explained me prerequisite, you explained me the twin delivery, but there might be something else which is there in the script, and I wanted to know that also. So here it's always better, what are your objective, or what we are going to, what are your expectation from today's teaching task. This one question will allow you to conduct it in a proper direction, complementing wherever appropriate. So you were giving me encouragement, you were checking my knowledge, means you were checking my understanding, you were not checking my knowledge, but you were checking my understanding at an appropriate interval. The hands-on technique you didn't allow me to do. So checking, not checking my background knowledge, not giving me hands-on technique, that's the reason I'm giving you in communication with colleague borderline. Okay. Indication, contraindication you mentioned, prerequisite, classification, not classification, procedure you mentioned, and identify complications, any what, at what complication she is. So you mentioned pph, these babies are at risk of pph, you had also mentioned intervention, more need of intervention and increased risk of cesarean section. Those are another complication associated with resources feedback in the beginning you mentioned. So now preparation. So what are the preparations we are going to do now? Yes, very rightly mentioned that these pregnancies are high risk pregnancies. The patients will be booked under a consultant led care. Make sure that there are no contraindication to vaginal delivery. Along with that, first twin will be cephalic, which you mentioned. That can be confirmed by ultrasonography. Mm, Dual channel CTG monitoring machine will be available throughout the labor monitoring. IV line in situ, group and save at risk of PPH. These patients are at risk of PPH. So you can group and save in those cases where the patient's risk of PPH is pretty high. Check recent FBC or full blood count. These are one point which you can mention. Ensure that first win is where IV line, group and save, check recent full blood count. That also can be an additional. Now, two sets of equipments. It is very, very important. Did you mention this, dear?
Yes, ma'am. Two sets. Yeah.
Yeah. So two sets of equipment, two skilled midwives, two pediatrician and anesthetist. Anesthetist for epidural also. And since these patients are, sorry, since these patients are at risk of what we can say, since these patients are at risk of intervention, at risk of cesarean section, theater will be alerted. Ensure early and easy access to theater if second twin will be non-vertex presentation. Access to ultrasonography and oxytocin drip will be ready. These are my prerequisite. Access to ultrasonography, did you mention? I didn't mention in my points.
No, you prompted me then. Like, is the USG scan needed in
Yes.
the?
Yeah. Okay. So this point you had not mentioned, but it's okay. Mm, one or two prerequisites can be here and there. Now conducting the delivery of the twin. So the twin one, if it is cephalic, how you are going to conduct? You are going to conduct twin one delivery as a singleton delivery. Singleton dual channel with continuous fetal heart rate monitoring. This can be conducted by a trained midwife because this is like a primary or a multigravida who is delivering for the first time. So singleton delivery can be conducted by midwife. Throughout the procedure, continue fetal heart rate monitoring. Role of episiotomy for first twin or second twin is not in general or not recommended unless and until we are anticipating any intervention. Okay, something like internal podalic maneuvers, all those maneuvers, instrumental deliveries. Then only the episiotomy is needed. Routine role of episiotomy is not there in twin delivery. Deliver twin and handed over to pediatrician. So this is another important point which you have to remember. Deliver first twin, handed over to a pediatrician as twin one for labeling. Not to deliver placenta at this time, at this point, and clamp the placenta. After delivery of the first twin, quickly examine abdomen to check for the lie of the second twin. Here, if you are not sure, you can use the ultrasound to confirm the lie and presentation. Now, if now there are two theories. If cephalic, it is easy. If abnormal, that is breech or transverse lie, then the action will be different. If it is cephalic, you can wait for some time, and you can allow your head to slide it down. Meanwhile, commence syntocinon. Along with that, uterine adequate means along with that, continuous fetal heart rate monitoring is very important. Once the contraction has been started and the presenting part has guided deeply engaged into the pelvis, okay, deeply engaged into the pelvis, rupture of membranes can be done at this point once the presenting part has been engaged, not to rupture prior to this, because again the risk of cord prolapse. Conduct the rest of the delivery as expected, or as expected. Handed over baby to the neonatologist, label and clamp the placenta. This will be your twin 2. Syntocinon drip, that is active management of third stage of labor, since the patient is at risk of PPH. Examine the perineum for trauma and manage accordingly. Note that the interval between two twins should be 30 minutes. Okay, so this most of the points you mentioned here, handing over of the baby to the neonatologist and labeling twin 1, twin 2, including cord clamping, you have to mention. These are the points which you had missed out on this point. Okay, not to rupture membranes, again also you have to say, because if the head has not been fixed properly, then before fixation of the head or engagement of the head, rupture of the membrane will lead to cord prolapse. If breach or transverse, uh, now, if breach or transfers, if it is a breach baby which has been confirmed by ultrasonography and there are no contraindication per se, so consenting is very important. Need of episiotomy is very important. Means here episiotomy will be needed. Verbal consent can be documented in case details. Adequate anesthesia or analgesia in the form of epidural analgesia can be done. External cephalic version or assisted breech delivery can be considered in cases of breech delivery. Continuous fetal heart rate monitoring is important, and expertise are needed, which you had mentioned very boldly, because that was mentioned twice and I listened to it very nicely, that okay, expertise are needed to conduct this kind of maneuvers. No, means you can take a help of the expertise, even the consultant can be involved here. If fetal distress, then at that point we can plan for cesarean section also. Any concern with fetal heart rate, any contraindication to ECV, assisted breech delivery or cord prolapse, then the cesarean section can be an option in this case. So this is breech. IPV in case of transverse lie. So if it is a transverse lie, then in that case the breech will the internal podalic version. That means the how you are going to do it. You are going to demonstrate something like that. Okay. So you are going to introduce your hand through the vagina, through the cervix, and then you are going to grasp the fetal fetal ankles, okay, or feet, and with the help of, and you are going to give a traction. Ensure here, because again there are chances of cord prolapse, and deliver this baby as early as possible. So as shown in this picture, you can do it, you can show it, and allow this maneuver to be done by the your ST2. If there is If there is time, locate the feet with ultrasonography, then insert the dominant hand with a long glove into the uterus to grasp the feet of the baby using external hand to stabilize the baby. Under all aseptic precautions, very important, under all aseptic precautions, bring down the feet through the cervix, and in the process, the baby will rotate. Risk of cord prolapse is always there. Okay, risk of cord prolapse is there. So this is a case of IPV where you are going to do IPV. ECV also you can show, but ECV they will not expect, might be IPV they will be expect. Now close the session by inspection of placenta. Means close the session means, now here you can just ask them that documentation, suturing any tear, inspection of placenta, debriefing to the patient. These all points can be considered in this case. And bladder care, resources and feedback. So in this case, what I will be saying, although you mentioned about resources, so it will be very nice if you will give them a proper resources, reading resources from where you are supposed to read, that RCOG, a nice guideline about twin pregnancies has been are there, and then even green top guideline regarding monochorionic monoamniotic twin. Even type of twin is also very important, that type of twin, which type of twin is it is, this is also very important, which you had mentioned, which you are mentioned under the heading of risk factor, but type of heading one can be said here. In means this these are my answer key for this twin colleague task. Anybody wants to add anything regarding this? Okay.
VT risk, ma'am.
VT per se, if it is twin pregnancies, less likely VT, but okay, you can ask.
Just
You
tell
can
like
ask.
risk
Yeah.
assessment.
Yeah, risk assessment
Like
is
last
basically
post delivery.
post
Also we
delivery.
can tell.
Yeah, only. Okay. You are going to give hands-on to the you are going to give hands-on to the trainee whenever there will be a colleague task, and especially mannequins are there. And two sets of everything was mentioned there. My concerns were very simple. Episiotomy, ultrasonography is needed, and one more concern was there, which was is ultrasonography when you are will allow perform breech extraction. Okay, so if ECV is not possible because of the high means activity or something like that, then and the breech has been engaged, breech has been already engaged, then in that case, yes, you are going to allow these babies to deliver by breech. Okay, in engaged breach, ECV can't be possible. Hmm? In engaged breach, ECV can't be possible. So information gathering, if you will see the domain-wise scoring for this task, information gathering, understand the need to first determine the skills of the duty. So this is basically important. What is, say, checking background knowledge is considered in two domain. So with this one point, you are marking your safety in two domain. Checking background knowledge of the trainee is information gathering also. Checking background knowledge with the knowledge with knowledge in this task, it will be again communication with colleague. In patient means in SPTs, it will be communication with patient domain. So checking background knowledge is very important. And then identify the gap in knowledge, skills of the duty, and correct him. Okay, addressed in the session. Timing interval between first and second twin, you had mentioned. Exclude all contraindication to vaginal delivery, you mentioned all those things. So basically this is information gathering in this case. Communication with patient and families, appropriate introduction to duty and our task to the patient and their partner. So whenever the structure discussion will be there or SCT will be there, so you can start after introducing to the patient. You will be conducting a twin after introducing to the patient and ensuring that all the prerequisites are available there. Then we are going to conduct the twin delivery. So this can be an approach when when the communication with patient and family domain will be there. Explanation, consent is again that communication with patient and family. Explanation of role of the duty, nature of the interaction to the patient. Informed consent obtained for teaching from the patient. Okay, so whenever teaching will be there on a live patient, if the communication with patient and family domain is there, you can ask them, we need to explain this to the patient that how we are going to, what we are doing, what we are going to do, and how we are going to conduct a twin delivery. Communication with colleague, so do two ways, how systematically you are going to conduct your teaching session and whom you are going to involve. So this two way in SCT it will be introducing self and role, understand the principles of adult learning, giving feedback with regard to twin delivery, appropriate steps of increasing clinical and technical skills of the learner, ability to use appropriate language, non-verbal clues to encourage learning, invite questions, encourage dialogue, checking their background, checking their understanding at an frequent interval. These all will be included in communication with colleague domain. Applied clinical knowledge, whatever knowledge you were having regarding teaching of the twin delivery was appropriate, what I feel. So clear pass in this domain. We will means there is person not mentioned anywhere from where we need to read about twin delivery, but this task per se is sufficient from where these are the points which you need to mention for twin delivery. So far as a very good task and very good presentation. Anybody is having any question? Anybody?